the action potential, and then what's resulted from that is our EKG tracing. And what I'm trying to get across to you with the QRS is with this phase 0, again, we have sodium flowing into the cell, and this represents our QRS width. And again, if I'm blocking that, I'm going to have a problem with depolarization of my ventricles. Those ventricles are going to take longer to depolarize, and it's going to be widened. And that gives us the evidence that we need to give sodium bicarb to the patient to overcome that sodium channel blockade. And this is, again, a very nice depiction of just that slurring of the action potential resulting in what we see on an EKG. All right, again, I give a blocker, I'm not able to get this in. This is very simplified. I'm not talking about open and resting states and inactivated states of this channel, but you get the point. I'm having a hard time depolarizing the cell because of a sodium channel blocker. Very germane to cardiovascular toxicity. All right, let's move on to the ST segment because I really want to hit that QT interval. This is isoelectric. Again, it's phase 2. It's that plateau phase of our action potential. And that's what's represented there, the end of our QRS to the beginning of the T wave. There's no net current. And again, we have calcium going into the cell. We have potassium flowing out. There's no net. So we have this phase 2, which we see on the action potential here is just a straight line, and that's really what we see on our EKG. Now, just kind of food for thought as we talk about this later, if I'm hypocalcemic, I now don't have a good ability to get calcium out of the cell, and if I don't have that ability, this gets a little prolonged. So if I'm hypocalcemic, I'm going to be increasing this, and then it's going to be longer for this phase 3 to occur. I'm having basically a lower depolarization threshold or lower resting potential, so you can imagine that this action is all going to take longer, and that sometimes gives rise to a prolonged QT interval. But a little bit more important about the QT is potassium. So the T wave. What is the T wave representing? The T wave is basically ventricular repolarization, resetting for a next depolarization. And this is where we have potassium flowing out of the cell, an outward flow of potassium. And this is depicted on our action potential by phase 3. Much different than phase 0. I can't tell you how many times I hear, oh, the QRS was, or the QT is long, so we're giving sodium bicarb. That's really the wrong approach, because if our QRS is wide, we want to overcome that with sodium bicarb. If our QT is prolonged, could be here a completely different mechanism, more indicative of having a tough time to get potassium out of the cell, and again, having a slurring in our repolarization. Potassium flux, this delayed rectifier current, very important in dictating what the QT interval is. So again, I've got potassium flowing out of the cell that gives us that repolarization, gives us that T wave. If I have a blocker here, I just can't do it, okay? This is a channel blocked by a drug. Maybe it's haloperidol. You're on the phone, you're speaking to someone, they gave them Haldol, and lo and behold, hey, they go into a dysrhythmia. Well, they look at a pre-EKG, a post, and now their QT is much longer. It's because I have something blocking that ability to get the potassium out of the myocyte. So again, we see this nice depiction of slurring occurring of that phase 3. So our potassium efflux blocker is really what's important in prolonging the QT. Okay? And if I prolong that QT, my heart is trying to depolarize while it's trying to repolarize. So you can imagine trying to stimulate a contraction while I'm trying to repolarize can cause problems. And that's where the dysrhythmias are going to occur. So what is this QT? What's interesting about it? So it's the time for ventricular depolarization, like we mentioned, the QRS, and repolarization. So it's the beginning of that QRS to the end of my T wave. Now, if we went around the room and we checked everyone's QT interval, there's going to be great variability. And you'll read in books, you'll look on your poison index or your references in your poison center, and for a male, if you're less than 450, for females, which are usually a little longer, less than 470, they say it's normal. How do you come up with these? It's interesting, the formulas that are used. There's several formulas. A lot of these are rate dependent. So if I have a normal heart rate, this Bazette's formula is pretty good. The Frederiциan formula, again, depends on rate, and there's a Framingham model which uses linear regression to calculate this. You know, if you ever do have a patient and you want an EKG faxed to you so that you can show your backup director or on-call person the next morning, you know, by all means get it. And usually you're going to see it listed at the top of the EKG, much like I showed before. And I think for the purpose of this, I think that's fine. I mean, we can debate which formula is best and so forth for quite some time. So again, we're talking about potassium efflux, our ability to do that, affecting this phase 3, which is then going to affect our repolarization. And really, this is what's important, and this is what's the most interesting and impacting factor, which determines our QT length. And the longer that QT is, again, I'm trying to depolarize in the face of repolarizing. Now, in the mention, I made this controversial statement about we have to speak about PMS to talk about this topic, okay? Obviously, I'm not going to talk about PMS. I'm going to talk about PMS, protoplasm, okay? We have to talk about the patients themselves prior to their toxic insult. We have to talk about their milieu, what's making them up as they come into the hospital and coming into our ED, being directed to your poison center. And then we have to talk about the situation that surrounds that patient presently and why that QT might have been prolonged, or why are they walking around with a prolonged QT. So when you talk about protoplasm, it's interesting because I sometimes, when I see my patients, I question, you know, what's the baggage this patient's bringing with them? And that could be past medical history, that's the drugs they're on, that's the drugs of abuse that they do, that's their genetics. I mean, you look at this picture, I mean, there's a couple of things you can see here. You can see, you know, an Eskimo looking into a cave, you might see an Indian looking out, and really it would be great if we knew everyone's protoplasm, but obviously we can't do that. But it's very important when we're talking about QTs. You've all probably heard of long QT syndrome. You probably have heard it in the context of a teenager playing basketball and collapsing, and then they find out that the patient had a cardiac defect, or they have a family history of cardiac defects. These are a few articles looking at long QT syndrome that I thought were very good. One out of New England Journal, they talk about initially a case vignette of a 13-year-old who had a sudden death after playing basketball. And then they talked about the whole workup of the family. Again, going back to protoplasm. What is this patient's makeup? And they go into the hundreds of mutations and the 10 genes that are involved with how long our QT is actually going to be. And again, that goes back to the protein that's coded for that potassium efflux. So again, this is the protoplasm that I'm getting at with this PMS model, and that's really my message today. I mean, again, this long QT syndrome, common for patients who are presenting with syncope, palpitations, cardiac arrests, especially again in young people. Another article that I thought was very good focuses on these genetic channelopathies, specifically this inability to get potassium out of the cell. It really emphasized the variable penetrance. Again, if we went around the room, we checked everyone's QTC, everyone's protoplasm, if you will, we'll find that it varies greatly. Okay, so we may be 470 and somebody else might be 480, somebody might be 430. Well, what relevance is that? Maybe none, but again, if the stars are aligning and they're on certain meds and it's their time, it might be important. So again, variable penetrance, they talk about the 3 most common types of long QT syndrome, long QT1 actually being the most common. They talk about different morphologies of the T waves, which I can't really understand, to be honest. But again, a swimmer who drowns and has no other medical problems, someone playing basketball and dies. Interesting, long QT2, they talk about loud noise or sudden noises being a precipitating factor in these folks having a cardiac event. They even want them to not have alarm clocks. I mean, that's amazing that might set their heart off. But it goes into the different risks and influences, the penetrance, and I thought it was a worthy article. So how long is too long? I talked about normal. Is there any evidence on what QT length might be worrisome? And I think what we have to do is kind of extrapolate our tox patient or our patient that we're dealing with on the phone with what we know medically. And we do know that the longer the QT in someone with long QT syndrome, specifically those who were greater than 500 had over 70% chance of some kind of cardiac event or syncope or some related symptoms with that level of QT prolongation. And I think also in tox land, when we have somebody with a long QT, we have to think about a little bit more, is this QT now long? It was previously short. The rate in rise of QT prolongation, the absolute change in QT prolongation from their baseline, because what we really want to know is the clinical relevance. I mean, looking at numbers is one thing, but what's clinically relevant? So I think for me, I like the number 500 when I'm worried in the tox patient. So let's talk also with long QT syndrome, the protoplasmic paper here from JAMA did a very good job, and I think I really liked it because it shows the different genes, the different long QT syndromes when they were discovered, and it really points toward what I talked about earlier with the pathophysiology, this ineffective, delayed rectifier current, this potassium getting out of the cell is just not as good as a quote-unquote normal state. So that's really what we're dealing with. So that's the P, protoplasm. M, milieu. Okay, again, this is something that may be a little bit easier for us to think about because we don't know the patient's genetics when they arrive. We can kind of look at their lights, their electrolytes here, and get some information that might make them at risk. Now, I talked about potassium efflux. If my potassium is low, I'm hypokalemic, I'm having a tough time getting that out of the cell, and you can imagine my QT is going to be prolonged. I talked earlier about hypocalcemia, which lowers our resting potential. Okay, now it's going to take longer to get down to that resting potential if I'm hypocalcemic. Magnesium is interesting because even if I have, magnesium and potassium are kind of cousins. They work together. If my magnesium is not available, the sodium-potassium ATPase is not functioning. So even in the face of a normal potassium with hypomagnesemia, I'm functionally deficient. I can't repolarize very well. So these are quite important when you're thinking about the QT. And I think in terms of milieu, very important in terms of what we might recommend over the phone. Also, drug-drug interactions. If I have a drug that blocks that potassium efflux, and I have other drugs on board that might inhibit its metabolism, a CYP450 enzyme, for instance, I have more parent compound around and maybe more potential for that effect to occur in a prolonged QT. And this is a busy, busy table, but I think it's really interesting, and it comes out of academic EM. Michael Shannon was the senior author on this. And I haven't memorized all of these, but I commonly refer to it. And I mentioned earlier a patient getting haloperidol in the emergency department. Well, if that patient's on T3s and they're getting codeine, they're on dextromethorphan for a URI, and they have a normal QT, but we know haloperidol can prolong the QT. There's evidence of torsades with rapid IV infusions of Haldol. Maybe I can cause harm in somebody because I've got a milieu issue. I've got some drug-drug interaction that's going to prevent that parent compound from getting metabolized because I'm interrupting its metabolism. So that's the P and the M. Let's go to the S of the PMS model here. Situations. Okay, what's the situation? You know, when I did trauma rotations as a student and resident, patients brought in, they've got a femur sticking out of their leg. Everyone goes over and starts, wow, look at that bone. Wow, look at that leg. It's turned all the way around. And no one's paying attention to the airway. Obviously, somebody is because somebody more senior is there. But I remember looking at an injury and not focusing on what's important. That's what we do when we get an EKG and they said, oh, they got a prolonged QT. We just focus on the QT rather than protoplasm, milieu, and what was the situation around this? Did I cause an issue in this patient's presentation that might have prolonged their QT? Again, a busy slide. Out of University of Arizona, you probably know about this website, but it gives us drugs that have